TRT, HRT, and heart valve replacement? That's a question that I got from TikTok today from the UPS man.
All right.
So I think today with that question, maybe we should talk about heart health and TRT.
Sure. I think it's a really valid thing. And I think the heart kind of comes up in, it comes up in this frequently. I think people are concerned about their heart, specifically in guys that have maybe had something that's happened. And they're not sure, right? Is testosterone for me? I'll give you just case in point. I just had a gentleman come in. It was a 75-year-old guy. He was actually a former patient of mine in the urology office, um, and he came in to get checked out because he's having some issues with erections and everything else. Obviously,
Mm.
75. Um, and not like a healthy 75. He's not bad, but like needs some help, needs some
Yeah,
work for sure. But could turn the corner if we do the appropriate things. And he was like, yeah, my family doctor doesn't want me doing testosterone. And I was like, well, why? And he said, well, because it's going to cause me to have a heart attack or a stroke. And I was like,
jeez.
haven't heard that one before.
First time hearing that.
Yeah, like really? Okay. Um, so it comes up. And he wanted me to call his PCP and talk to him about it. So I did. He was busy that day, which respectfully, I mean, like PCPs are busy. So like again, I'm not here to throw shade at any doctor or whatever. Again, I worked in that element for a long time. I get it. I get it. He eventually did call me back a couple of days later, so I was very thankful for that. And we talked for a little bit. And I told him what I wanted to do. And it was funny. He was like, "Well, what kind of testosterone do you want to put him on?" And I was like, "Well, for him, I'm thinking more of a cream because he has ED, he's 75. We can be a little bit more mild on that. Plus, it generally benefits ED better because of increased DHT production if we do a transcordial route application." And I was like, but to hold you at that, it doesn't matter if he injects either. It all works the same. Like there's
Right.
no like
Yeah.
if I
Yeah.
put it on topically or if I inject it, it's still the same thing that happens in the body. Like there's no magic switch there.
Right.
Um, so I kind of chuckled at that. I tried to educate him, but you could just tell he wasn't feeling it. So I didn't press my luck, and I got out of Dodge quick. And he gave him his blessing, and so
Oh,
we're
he
probably
did?
gonna
So he
start him
gave
on.
him the okay?
Yeah, I mean, like there was no reason he couldn't. There was no refute there because I
Right.
think any question he had, he pretty much knew I was going to have an answer for. Um, and I did, and I told him, like, listen, I worked in the urology office. I did testosterone there. I was like, I've since, gone way above and beyond what I was doing there, like well beyond light years beyond that. And I said, so if you have any questions, reach out. I haven't told him about this podcast. I was like, come listen to some episodes. So then, like, do I think he's going to listen to some episodes? I don't know. That'd be great. If you're listening, thank you. I appreciate you coming, listening to our content. If not, that's okay too.
Yep.
But I was just glad he was open to the discussion, and he did. So at any rate, we're going to start that gentleman on testosterone. But the heart issues, right? We obviously get asked a lot. It was asked about that particular gentleman. Um, what do we do about that? Um, First off, does testosterone affect the heart? Indirectly and directly, it does. And what we're looking for, at least when we're starting, somebody on testosterone replacement therapy, uh, is, I will obviously do a cardiac history. Have you had an MI? Have you had strokes? Have you had stents done? Have you been cardiac cathed? Yeah, I actually had one gentleman that we started him on a cream. Actually, he was another older gentleman that got referred to me by a PCP who's actually a colleague of mine, and a friend. And we helped him out. He was able to achieve his goals, but he ended up having high blood pressure.
Mm.
It was underlying. And then he ended up going to do a stress test, failed a stress test. They cathed him and he ended up having like 2 blockages and they stented him. But then
Jeez.
since he was stented, he was on Plavix and some blood pressure medications and then he just started to not feel good all the time. And eventually he came off testosterone and to the expense, like he just didn't want to pay for anymore. So, um, the woman that he was with was like manipulating him and left. And I think he was just like, I need some time for myself. I'm like, take all the time you need, brother.
Hmm.
But like he would have been a good candidate to continue with testosterone because he was post intervention because it definitely would have helped him in the long run. So what are the things I'm looking for in people that have heart issues? Um, Obviously, severe uncontrolled hypertension before they come in, that needs to be mitigated before we start testosterone. Testosterone can increase your blood pressure, and we see it happen frequently, actually.
Yeah.
Some of it's mild and I don't worry about it. But if you're already significantly elevated with your blood pressure and it's not mitigated, we don't want to put you on something that can make that worse, because that's going to cause some strain on the heart and the coronary vessels. So, um, obviously, any known androgen abuse will significantly increase your risk for heart issues. No offense to the people that want to do that. We are not throwing shade at you for
Yeah.
doing that, making that life decision, your life to live, but it's not a great decision for your heart health.
Nope.
So that is well known, well
Right.
documented. But just testosterone by itself, I think because of those anabolics, it's this misnomer and it bled over. And that's kind of where we're at. That's what lands us in hot water. Everybody's afraid. And there was some earlier studies that I think were done wrong, and in my opinion, maybe done to propagandize testosterone in a negative light, which is why this stigma exists, right?
Hmm.
To kind of shy people away from ever wanting to do it because it's unhealthy and it'll kill you.
Right. That's
When in
exactly.
reality, it's far from the choice. I mean, look what
Yep.
happened to Women's Health Initiative. You
Hmm.
know, when we talk
Exactly.
about that, that's the same type of scenario, but just with women, right? We have a study done with synthetic estrogens and progestins. They do have an increased risk of clot, stroke, whatever, but it's the synthetic progestins and estrogens, not bioidentical progesterone and 17 beta estradiol. So, did anybody come out and say that? No. They just
Doesn't
kind of
fit the
labeled it
narrative.
all under one. And now we've had 2 decades of women that haven't had proper HRT and they're suffering because of it. And the crazy thing is we were using, prior to the Women's Health Initiative, women were successfully being treated with HRT well into their later years. It was like normal. And that came out and changed that landscape.
Mm.
So that's what I mean. And I saw this too with the PSA. I don't did we do an episode where I talked about the PSA and how the United States Preventative Service Task Force used the PCLO study, which is the prostate colorectal lung ovarian study proxy, where it showed that screening for PSA wasn't worth it. So they recommended stop screening PSAs on guys. And then when I started in urology in 2018, they finally like reversed that decision later that year, but the damage was already done. It was like
Right.
almost a decade of guys not being screened for prostate cancer.
Yep.
So we had guys coming in with like full blown metastatic prostate cancer that we'd never seen before. And we're like, how did this happen? Because family doctors stopped screening. I
Jesus.
mean, they were just following their guidance, so I don't blame them.
Right.
It's not their fault, but like, and then you find out the United States Preventative Service Task Force, the person that made that decision was a pediatric cardiologist, like had
Jeez.
no real reason to even be making decisions about that, who was, kind of the head of it. And but this is how I mean, like when we're looking at data and we're looking at things that influence things, we really have to dig. And you can't take this stuff for face value. So, and that was the case for testosterone, why it got like a negative opinion, uh, you know, and this is where we're at right now. So
Yeah.
the question was about heart valves
Yes.
and TRT. I actually got this message from this particular gentleman as well. And the answer is it's 100% A-OK to be on testosterone and have a heart valve. And I think the other question with this was due to anticoagulation. In this case, this particular person, because it is a mechanical valve, will need to be on warfarin or Coumadin, same thing. And that's done differently than your factor 10A inhibitors, which are going to be like Eliquis or Pradaxa is another one. And they're probably going to be on some type of antiplatelet medication as well, like Plavix. There's an IV version of it called clopidogrel. That's obviously not used in like ambulatory setting. That's going to be a hospital only setting stuff. But they're going to be on that because obviously platelets aggregate to form clots, and then the factor 10A inhibitors really just extend the cascade of clotting. I think when people that they don't understand is when you form a blood clot, it's not just like clots formed. Like it doesn't work like that. It's kind of like a series of reactions that happen, and like you have like step A, step B, step C, step D, clot, right? And that takes some time. So what warfarin does is it sort of like elongates steps. Okay.
Right.
In sort
Okay.
of a layman's term. So if step A takes 10 seconds to go to step B, if I give you warfarin, it now takes 20 seconds,
Okay.
based on whatever your levels are. It could take 30 seconds. It could take 40 seconds. I'm paraphrasing that, but that's kind of the
Yeah.
general
The point.
idea
Yeah.
of how it works. Okay. Uh, and warfarin's actually rat poison. That's how they figured that out.
What is it really?
Yeah. Actually, there was a guy that tried to kill himself with it and he didn't die. And he went in and just found his blood was really coagulated. So, but that's what it was. It was actually rat
That's
poison
true.
first.
That's how they figured that
That
out.
is very true. Yep.
Sweet Jesus.
Uh-huh. Yep.
Huh.
So it is. If you Google it, I'll type in it right now. So warfarin is rat poison.
Did the guy benefit at all, like from it financially? Because I mean, it's like,
What's that?
did he benefit at all financially from it? I mean,
I don't know.
could
I don't
have.
know if that happened before or after, but it was used as rat poison. It soon became both the most widely used rat poison and the most widely prescribed blood thinner in the world.
Holy smokes.
So yeah, it's kind of a neat story behind it. But that's true. Like it was used as rat poison. So um, you know, that's what that kind of started.
He should have gotten some money out of it.
I don't think it was like the guy that like I don't know if it was like her creation or if like I don't have those details, so I don't have that like deep dive of the history lesson in front of me. It's just I've just known that it was rat poison for years. So, but no, all that is going to do is like I said, extend out your blood. We call it a thinner. It doesn't actually thin your blood. Okay, I don't know. I think the thinner is the misnomer here. It elongates how long it takes your blood to clot. So in terms of warfarin or Coumadin, it's going to be a PT, a PTINR. Okay. Excuse me. And that's going to kind of measure how long it takes. And then PTT or a partial thromboblast time is going to be for heparin, which is kind of the IV equivalent. Sub-Q, you could give it sub-Q as well. Equivalent. And oftentimes people will bridge because Coumadin takes a longer time to work. So we'll bridge people with either heparin or low molecular weight heparin. This is called Lovenox. They even have a even farther ones called Fondaparinux, but I haven't seen that one used in years. It's mostly just Lovenox or heparin. They'll bridge until they get them because they work on two different pathways until warfarin's good, and then they'll pull the heparin.
Right. Okay.
And then they'll be anticoagulated. But no, totally fine. Testosterone's not going to interfere, and cause you any more heart problems because it never causes heart problems like that. Indirectly, what are going to be your benefits from being on testosterone in relation to your heart? The majority of these are actually going to come from estradiol. So, I mean, we always talk about not blocking estrogen, and it's really, I mean, there's several reasons why, but the heart's one of the main reasons why you don't want to block it because it's indirectly going to improve these things. So we're going to have better fat metabolism, and over a period of time, about a year after you're on TRT, we're going to start to see visceral fat reductions in patients. And we know that reductions in visceral fat directly, or let me flip this. High visceral fat loads increases all-cause mortality.
Right.
So if we reduce that, we reduce our all-cause mortality. Okay. So there's that. We also have the effect of estradiol causing insulin sensitization. And we're better able to use glucose as a fuel source more efficiently. We don't have to secrete the higher levels of insulin. And we already know that diabetes is, probably combined with obesity, the top two comorbidities in the world.
Yeah,
definitely in the United States.
Yeah.
So, those are things that'll help with. And then two, the creation of muscle mass. Everybody thinks that like, yeah, I take the steroids, I'm going to gain all this muscle. And it's like, you'll gain muscle if you actually put the work in, but like, you're not going to put on a lot of mass if you don't go to the gym to actually try to put it in, and also make sure your diet is proportionate to create that recovery to gain that mass.
Right.
But higher muscle mass individuals have an increased longevity. Okay, we see that in exercise endurance, and there's even studies coming out now that increased VO2 max directly relates to
Yeah.
longevity as well.
Yeah.
So, and we're seeing that, and testosterone will increase your VO2 max because it's going to increase your exercise capacity. So it's just going to be like step one, step two, step three, and it's just going to kind of phase into all of that.
Hmm.
So we will see that. Those are all very heart healthy things. Um, it's going to improve your blood pressure long term. Not immediately. It actually will increase your blood pressure,
Right. Yep.
within like the first 6 months. And we see that quite readily. But over time, as you have these other metabolic events happen, in terms of muscle creation and, using insulin better and everything, your blood pressure is going to start to normalize and come down. Now, if you continue to eat cheeseburgers and live like a slob, no, it won't. But you know, hopefully you now have the energy and the wherewithal, and you want to go to the
Right.
gym and you want to
Yes.
make that change. And this is obviously kind of the underlying tone behind sort of this podcast, is that we didn't like the life path we were on,
Yep.
and we obviously realized we had a deficiency and we corrected it, and now we're on a separate life path, right?
Right.
And we want to walk this other path. We don't want to walk the path we were on. So let's actually walk that path. Let's get the most out of it. We're going to have the tools in place to do it. Let's use them,
Yeah.
and let's gain everything that we had wanted out of that, and that's what will be achieved. So yeah, it's definitely, a very beneficial thing for the heart, in terms of that. The flip side of that would be, there's a lot of studies out there that show that low testosterone directly increases your
Yes.
risk for heart attack, stroke. And
Right.
and so there's a ton of studies out on that. I don't need to get into all the data on it. They exist. A quick Google search. I don't even have to go into like any of the databases to pull that one. They're real easy to find. And they'll easily show you a correlation between low testosterone and increased cardiovascular events. And I think that's why some cardiologists that are pragmatic and progressive are actually giving guys testosterone that have kind of low testosterone to help prevent any future heart problems,
Mhm.
moving forward. So yeah, hopefully that answers that question.
Yeah.
It can get a little bit more nuanced, but I think I don't want to go too far into the weeds.
Yeah. Well, I mean, and what about if like guys have had heart issue, like maybe they've had a heart attack at some point, a few years ago, what like is there a time period in which you shouldn't say you had a heart attack,
I mean, um, necessarily no. And I mean, does that mean that you want to jack your levels to like 1500? Probably not. But does that
right.
mean if your levels are like 200, we can't get you to like 800 and get you into like a much more stable regimen to where you're starting to feel good without causing like a lot of stress, on your body
Yeah.
as you recover? Because here's the thing: if you have a heart attack and you get stented or whatever, you fail a stress test, what do they put you through? Cardiac rehab,
Mm-hmm.
right? And what's the goal of that? To kind of stress your body out in order to, kind of get back. So these people are doing like treadmill walking, and, because they're so short of breath. And
Yeah.
because if the heart gets damaged from the heart attack, and an area of the heart can't function well, it's not going to pump very well, and you're going to start to have fluid backup. And
Mm-hmm.
these are all things, and depending on how bad your heart attack was, that we have to kind of work through. So these are some things that you do, but can you come back strong? Absolutely. It's totally doable.
Yeah.
But again, you kind of have to use that, and there's no contraindication that said that, hey, I had a heart attack. Can I use testosterone? Yeah, absolutely. And if you're hypogonadal, I highly recommend looking into that. Don't let your prior history of a heart attack. Matter of fact, if you had a failed stress test and got stented, come my way. I will be happy to take care of you, because then, like, I already know your risk is
Right.
mitigated. So,
Exactly. Yeah.
like, you've already been cathed. I know each vessel, how narrow it is, and the narrow ones got stented, and we're good. Like, so
Yeah.
we just can use that as a tool to be like, listen, we've now had all these, fixed. Let's start working on so that we create no future problems anymore, and let's do it a healthy way.
Right.
And so yeah, I'm all about that.
Yeah. I mean, have you ever had to turn anyone down? Like as far as maybe had any kind of condition or heart condition? you know, that you weren't able to start them on, or maybe had to
The
delay it
I
to,
haven't had to turn anybody away yet. I'm sure it could happen, and
right?
I'm trying to think of a scenario off the top of my head. Um, I think it would just be somebody that's like extremely high risk with, it's like a time bomb.
Yeah. So I mean,
It's
I guess the real
like, for
question is,
example, I don't really like to treat smokers,
oh,
right?
okay, yeah, there you go.
Um, for like a long time a smoker. It doesn't mean that I won't, but we're probably going to talk about that, because smoking is sort of antithetical to being on TRT.
Hmm.
Like, you're trying to make yourself feel better, but then you're going to do a destructive behavior
Right.
at the same time. It's like same with alcoholism, right?
Yeah.
Like, and that's, you can't really be an alcoholic and do TR. I mean, you can, but like it goes against what you're trying to do.
Yeah.
Like, if you're trying to get healthy, you can't crush a case of beer every day on the weekend. Like,
Yeah.
it just
Exactly.
doesn't.
Right.
You're not gaining anything out of that.
No.
So does it mean you can't have a beer? No, you can absolutely have a beer. That's totally fine. You just can't crush a case,
Right.
or drink in excess, because it's not that it's not healthy on TRT. It's not healthy at all.
Yeah. Exactly.
So
Yeah. I mean, is there any heart conditions in which that you can't do TRT that you can think, or is
off the
everything?
top of my head, no. I mean, I'm just gonna think of, like, kind of the major, heart issues. I mean, obviously, if you had some type of valvular disease, no, there's no contraindication for that. Some people will have some blood pressure issues, like, for example, like aortic stenosis. They could have some blood pressure issues because of the bad aortic valve. But if it gets replaced or repaired, then that usually mitigates that. So no, I mean, you could, yeah, I guess if you had somebody with severe aortic stenosis with uncontrolled hypertension, then yeah, that'd probably be a contraindication, at least until they got that fixed.
Okay.
Yeah,
All
because
right.
I wouldn't want to increase their blood pressure anymore and cause any problems,
Right.
um, in that particular person until they had that fixed. So I'm not saying no, I'm just saying there's an
Yeah.
order of operations
Get it
here.
right. Okay.
Yeah,
Yeah, that makes sense. Yeah, I mean, I guess a lot of this stuff comes from, I mean, you would think it's probably from the guys that abuse testosterone,
it
the
is.
heart,
Yeah,
issues and stuff that come. Because I mean, obviously they're abusing it. God knows, I don't know how many get blood work and
sure.
do it, and then
Well, I mean, you think about the things that change from the anabolics, right? We're going to have a skew in our lipids. Okay, so we're going to have HDL crash. We're going to have LDL go way up. Um, our blood pressure is going to shoot extremely high. Okay, while we're on that, and now we have high blood pressure, negatively skewed lipids to sometimes pretty terrible levels, like extreme levels, like LDL's over 350, like just stupid level cholesterol. Um, and what happens is, cholesterol is your repair in your body. And if you have super high blood pressure, even for a period of time, and it causes vascular injury, your cholesterol is going to repair that.
yeah,
And that, because that's what it does. And, you know, the when you're not supposed to be having this stress on your heart and your coronary arteries, which is the big one, because if you have that continued high blood pressure and you repair that damage with the cholesterol, that's how we get our, narrowing in our arteries, and eventually it gets so occluded that it either you have a heart attack or it breaks off and goes downstream and gets stuck.
mm,
And those are the things that happen, and that's just like the heart portion of it. I mean, we're not even talking about the when you add
yeah,
50 plus pounds of muscle
right,
in
exactly.
six
Yep,
months,
yeah,
the stress that it puts on your heart to now be
just do
oxygen
that, right.
to muscle tissue.
Hmm.
You know what I mean? And it stresses it out. And then you get left ventricle hypertrophy. And because the heart has to beat so much harder to meet the metabolic demands of the body. And once you develop left ventricular hypertrophy, it doesn't go away. It's permanent. And what happens is the fraction of blood that your left ventricle can eject. And mind you, you have obviously four heart chambers. You have two atria, two ventricle. Your left ventricle is the one that pushes it like out to your body. So your right ventricle pushes it to the lungs. It comes into your right atria. through your right atria to your right ventricle to your pulmonary vein, if I'm correct, goes through your pulmonary, oxygenates. Yes, pulmonary vein oxygenates pulmonary artery, left atria, left ventricle, out, okay,
Right.
to the body. And then that squeeze from the ventricle is actually the squeeze that also the coronaries branch right off of that and go right back into the heart. And that left ventricular pressure is what feeds your heart itself. Like that squeeze needs the blood to go out, hit, and then push the blood down to actually feed the heart tissue itself. So it's kind of like a pump that supplies its own power in a
Right.
way,
Right. Exactly.
right?
Yeah.
And that's like when we have a heart attack, like where the pump's not getting the power it needs because there's something blocking oxygen from making it to that portion of the heart, and it
Right.
dies, and the electrical system in the heart goes haywire, and you can have crazy arrhythmia. You can have a ventricular arrhythmia, which all but VTAC, pulsed VTAC is perfusing or non-perfusing. So if you're a pulseless VTAC or VFib or asystole, those are all non-perfusing rhythms. When I say non-perfusing, there's no blood being squished from the heart at all,
Yeah.
and
Hmm.
and then that's going to lead. You're not going to have blood go anywhere. Your blood pressure is going to go to zero. You're going to be unconscious. But so it has to go shoot out for that left ventricle. But if it gets hypertrophied, its ability to squeeze the blood efficiently goes down. Think of it. If I add more muscle, like I'm not agile anymore.
Right.
Right. Like, I'm blocky, I'm kind of bulky and everything. And if the heart gets like that too, its efficiency to be able to squeeze the blood, goes down. So we have that's called an ejection fraction or an EF. And you want that to pretty much be above like 55-60% at all times. So when we start to dip below that, then that's called heart failure.
Hmm.
Okay. And then that can cause a myriad of problems. So there's some things that, doctors can do. There's some inotropics, chronotropic drugs that can be used. That's getting real into the weeds.
Yeah.
To kind of help increase efficiency, preload, afterload, again, super into the weeds. But take care of yourself. You get one shot at this, you know.
Yeah.
So
What about guys that have enlarged hearts? Like
that's
that's
what that would be. The enlarged heart would be
yeah.
physically the heart muscle grows.
Right. But I'm saying if before they started TRT, like is that a
That's usually
problem?
not. Well, I mean, it's going to be enlarged from something,
Right.
right? So the guys that have enlarged hearts, we'll just talk about like Rich Piana. Everybody,
Yeah.
probably
Yep.
knows who Rich Piana. Rich Piana's heart was huge, but
Hmm.
Rich Piana's heart was huge because of steroids
Mm.
and GH essentially. I mean, I think he was talking about one of his cycles. I mean, they were doing like crazy amounts of steroids, and then I think he was saying he was taking like 2 to 4 IUs of growth like every 2 hours for like
Jesus.
12 hours a day. So he's putting in like what 20 plus IUs of growth hormone a day. I mean, that his cycle probably had to cost like 10 grand.
God.
So like ten to $15,000. Like it was probably stupid.
Yeah.
Um, but that's what's going to cause that hypertrophy in that guy. But just from like a regular person, they're not going to have, like you or me aren't going to necessarily have enlarged hearts unless we have a reason for it to be large.
Yeah.
So obviously, if somebody came in with an enlarged heart, um, like I said, that's not really a common thing
Hmm.
that you're going to just see in like your walking well population. And to date, I've never encountered that.
Yeah. Yeah. It just was because I've known a few buddies of mine we played sports when we were younger. And then as we got older, two of them weren't allowed to play anymore and I don't know the reason why, but I know that they had heart problems, but
Okay.
it wasn't anything crazy, but they weren't allowed to play sports
Sometimes
anymore.
you can have heart defects, and
Yeah.
those aren't found until later in life. I
Right.
believe there was this was like in the news not that long ago, I want to say. And like somebody died like running track or something like that. I can't remember. And they ended up in the autopsy, I think they ended up having some type of congenital defect that didn't get found later in life. And there's a couple you can have. There's atrial septal defects. There's like tetralogy, although that would have been found at birth because you would be blue. And
Hmm.
they would be like, oh boy, that's not good. So those tet babies are pretty much, nailed out right out the gate. And there's a couple other heart defects, and a lot of it sometimes is because the chambers of the heart, there's like a hole that maybe like connects the two atria and they're not supposed to, right? Or
Right.
there's a
Okay.
hole that connects the two ventricles. So like blood goes in one and it leaks back to the other, right? And you're not supposed to have that.
Mm.
And so that can cause some issues,
Yeah.
with how well you can pump blood through your body.
Right. So would that be like an issue that you couldn't do TRT
No,
if you
you could
had, or you
definitely do
could? Okay.
TRT for that. Yeah, it's not going to necessarily, disqualify you from doing it. Now, if you fell over because something happened because you were like going hard on the field or whatever, I mean, did
Yeah.
the TRT cause it? No, you went hard on the field. That's probably what caused it.
Right.
You know, but those are things sometimes that sometimes they don't get picked up
Yeah.
because this person's not going super super crazy, and those are extremely rare events, I'll put it that way.
Okay. Yeah. I mean, that's, I always remember as a kid, remember Hank Gathers?
Hank
Like
Athers.
Hank Gathers. He was
Uh-uh.
a basketball player from Loyola. He dropped over on the court when I was a kid. I remember it being everywhere
Okay,
on the news.
I think I remember hearing about that.
Yeah. And I think that he had some kind of birth or heart defect that
Yeah, that would
they
make sense
didn't,
then.
and he just, and I, right there, I've seen that a million times when I was a kid growing up on
Yep.
TV. And so that's what made me think of it because I knew too, right after that happened, actually, I don't know if that made sparked a debate and people, but like a few years later, one of my buddies, and then the following year, another one weren't able to play sports. And I never knew why, but I knew
Yeah,
it was something heart related.
that would get diagnosed with an echocardiogram. There's two types. There's a thoracic and then a transthoracic echocardiogram. Transthoracic, they actually go down your throat,
Yeah.
and they do it that way. And then the thoracic is obviously like right over your chest, and they can look at your heart. They're actually kind of cool to look at. If you Google some videos of like echocardiograms for heart, you can actually, it's like an ultrasound of your heart. It's really what it is.
Yeah.
And you can see the heart beating in like real time and like see the valves fluttering and everything. It's pretty cool.
Yeah.
Um, it's neat. It's actually really neat too if you see a heart that's like, let's say, atrial fibrillation or atrial flutter, which is a heart arrhythmia, atrial heart arrhythmia. Those people do have to be anticoagulated, because what happens is the atrial doesn't squeeze; it just kind of quivers,
Hmm.
right? It just, instead of like squeezing it out and going in, it kind of just does one of these,
Oh,
and so what happens is blood can pool in there, and they can form blood clots because it's not sucking it out and it's not moving it into the next chamber.
yeah.
So blood in little pockets in there could form a clot, and then you have to worry about blood clots,
Right.
pulmonary embolisms, those types of
Hmm.
things in those individuals. So they have to be anticoagulated, and they have to be anticoagulated for a period of time. And then they have to have, so I used to, when I worked in PACU, we would cardiovert these individuals. And a cardioversion is if somebody is in some type of like stable atrial arrhythmia. Okay. Um, it could be SVT, rare SVT. These are usually people in atrial fib or atrial flutter. SVT stands for supraventricular tachycardia. Sorry, I'm using my big words here. I need to not. Supraventricular tachycardia. It's basically an atrial arrhythmia. So top part of the heart beats faster than the bottom part of the heart. Okay. Um, and sometimes you can't get people out of that arrhythmia, and they would have to do what's called a synchronized cardioversion. And a synchronized cardioversion is we shock them just like you would shock somebody like clear,
Yeah.
but it's synchronized. And what I mean is it synchronizes is it delivers the shock. Do you ever see
Yeah.
like show ER and it's got the
Right.
EKG monitor
Yep.
and you see the beep with the
Yeah.
big spike, okay? That's called a QRS complex. Okay. Q is the beginning of it. R is the top. S is the bottom. Okay. QRS. I don't
Hmm.
know why they call it that. I probably should, but I don't. Um, it shocks on the R. Okay. So all the peaks, when you hit synchronize on like a life pack, which is what we use to do all of ours, you put the probes on, over the heart, and then usually one down on the side. You have to transect the heart. We want the current to go through it.
Through. Right.
Okay. All right. And that's how we did it in the recovery room. We would sedate them. First off, we would sedate them. We would actually use Brevitol or a barbiturate. And in some cases we would use propofol. We'd put them out, and then we'd paralyze them with succinylcholine so that they couldn't move anything. And then we would like dial it up. Or I'm sorry, we wouldn't. That was for ECGs. Or I'm getting them mixed up because we did both of these. That was for that's a wild one. We should talk about that sometime. They shock people. They induce a seizure to help them with mental health.
Oh, what?
Yeah, yeah, we did them all the time. And so I'm getting it mixed up. We did not paralyze for the cardioversions. We did for that particular procedure.
Oh,
But the cardioversion, we would just put them to sleep and then pow, and then zap them on the R on the thing. So when you hit the button, you see the movement
yeah.
of it, and then you would see this little line above it, and it was like a stock stick. It would just be like all the way, and then when you hit the button, it would have to sync up with that. And so when you hit it, it wouldn't shock them right away. You'd be like holding it, and then all of a
Oh,
sudden it would be
until it
like
got to,
whap,
yeah. Damn.
and it would hit them. And then we would wait and see if the rhythm changed. And if
Right.
it did, we were good. And then if it didn't, we would repeat it. And we usually did it, I think, up to 3 times. And we would increase the joule amount a little bit. And that was it. And if it didn't convert after 3, then we wouldn't cardiovert you. We'd just give you some meds, and hopefully we could chemically convert you. But yeah, I did that for years.
Yeah. Damn. Yeah, that's crazy.
And we had to do the
Well,
echo right there in the room before we did it to make sure that didn't have any blood clots in there.
oh yeah. Well, see, I was going to
Okay.
say blood clots. I'm like, that's why heart health, blood work, TRT is all essential.
Mm-hmm.
Because if you're not doing blood work, you know, who knows what's going on in there. And if you're not controlling hematocrit and all that, that's where this is where like the thing with the heart, people don't we always hear these things like, it causes heart problems, but we never know the full story.
Right.
You never know like how much testosterone was the guy taking? Was he getting blood work? Was he, we
Yeah.
never hear the whole thing. It's just
You
that
don't. You just get the
testosterone
excerpt.
causes, it's like, well,
You get, it's like anything else, right? You're going to get all the negatives and none of the context.
right,
Right?
exactly.
It's like any news story.
It's
That's
just
what it
the
is. It's
headlines. That's
all
what they're
negative.
trying to
Right.
get.
It's all
Testosterone
headline,
causes heart
no
attack.
substance.
Okay.
Yep.
It's like,
Yep.
but never the details.
Right. What's the context? I
Right.
want to know the context.
Yeah. And I mean, that's what I remember as a kid, it's all you would hear about is like testosterone, steroids gives you like you're going to die
Yeah.
because you have a heart attack. And
Part of me, like I said, I think it was done like that. And this is kind of interesting. I want to actually do some digging on this myself because I truly feel that some of those studies were set up in a way to elicit a result to make it look bad, to show this is why you shouldn't do it.
I believe it.
You know what I mean?
Yeah.
To
I believe it.
sway people into thinking. Because I mean, that's one thing about research when you're reading it. And obviously we use research as sort of our tool to, as data to advance, so we call it in medicine, we call it evidence-based practice, right?
Hmm.
You're going to follow evidence in order to practice. And in order to have evidence, you need to have studies, right? You need to have your data. And, obviously there's a hierarchy of data. We could probably do an episode on that sometime too, because not all studies are created equal. There are some that,
Yeah.
that
No.
don't hold a lot of weight, and there's some that'll hold a lot more weight. And you kind of have to disseminate, like, is it this type of study? Is it this type of study? Right? Like if it's a qualitative study, which is basically just like a survey for the most part,
Hmm.
is it providing you the same quality of data as if it's a randomized controlled trial? And the answer is no, it's not.
Right.
You're getting a much better generalized, controlled session period of data with your RCT versus if somebody just says yes or no.
Yeah. Well, I think we've
You know?
even talked about this before about different research and what they've done and comes like you're not comparing apples to apples.
No.
Like there's always apples to bananas. And
Yeah.
then, it's like, well, how do you come up with an answer if we're not comparing two things,
Right.
identical
Well,
simultaneously?
it was like that too. And so one thing with research, if it's a true phenomena, right? If it's something that we've hypothesized, we've organized a trial, we've organized an experiment to put this to test, right? Then that particular phenomena that's observed should be reproducible, right? Like we should be able to
Right.
do it in
And
like
then,
another setting with other participants and yield very similar results.
Right.
Right. So that's how, like, and I'll give you an example for the PCLO study that I was talking about with the PCA. There
Hmm.
was a European counterpart study, and I don't have the acronym off the top of my head right now, that did pretty much the same thing. Okay. It was a little different, not exactly the same. But in the European study, it was concluded that you should still do PSAs, that they found benefit in continuing to do them. And with the PCLO study, they found that no, you shouldn't. So here
Hmm.
you have two very similar study designs, right? With one saying don't do it and one saying do it. So what, like,
Right. What's
if it
the
was a true phenomenon or not, then it
right?
would either be both no or
One.
both
Right.
yes.
Right.
You wouldn't have this split. So what does that tell me? It tells me that something probably happened in that because they weren't reproducible, right?
Right.
And that's how you can sort of tell, like, if a study, if I do an RCT, randomized control trial, and we set it up and we just took people from, I mean, we'd have to randomize it to some degree, but we
Yeah.
took some
But
people from, general area here in Pennsylvania on like Philly, and we
yeah.
went to Pittsburgh and we did the same thing. We should get somewhat of the same results
Right.
with both sections of people.
Right.
You know what I mean?
Yeah.
So,
Well, that makes sense. Well, I think it started from the beginning when the enclomiphene study. That's how this all started with you know what I mean? They didn't compare one to it was comparing
mhm.
apples to oranges, you
Yep.
know?
Well,
And
I know we talked about that. That was never even FDA approved.
right.
Not
Yeah.
that things need to be FDA approved, but it does mean that
It's gone
obviously
through some more, yeah.
it's gone through some trial and error to get to
Yeah.
a point where they're like, yeah, it's probably okay. You
Right.
know,
Yeah.
so
Yeah.
and not saying that it's not. It just Repros Therapeutics couldn't produce the data whatever the FDA was asking,
Hmm.
and it was a very drawn off process, and I don't know what happened. That'd be a great documentary if they could.
To find out. Yeah.
So
Well, yeah, well, you know what? Yeah, I mean, this is the number one thing that I think people say about the negative things, like why they're not going to get on TRT,
yeah,
is because of I don't want to have a heart attack.
it's not going to give you a heart attack. It's not going to give you a stroke if done properly.
Right.
And even if it's done like improperly, I mean, you'd have to really fuck it up.
Yeah. Well, you'd be
So
surprised
yeah,
people do some dumb
and
things.
here's the thing: it's even if you did, it's not to say that you're gonna have a heart attack or stroke for it.
Right.
It's not gonna do that. It's
Yeah.
very safe. I didn't talk about Traverse. Oh my gosh, I completely left that out. Um, talk about that real quick.
Yeah.
That was what influenced the FDA, as we know, removed the cardiovascular warning risk from testosterone in April of this past year.
Yep.
Okay. They did slap a big old hypertension sticker on there, but they got rid of the cardiovascular risk study. Why did they remove the cardiovascular risk? That was from the Traverse study that came out in 2023. And Traverse was basically a randomized control trial that had the inclusion criteria for that was men who I believe were 45 years of age and older. Don't quote me on the top of my head. I'm paraphrasing. It could have been a little younger. But I do know that they all had to have 2 testosterone levels below 250 to qualify for the study. So if
Okay.
you weren't truly hypogonadal, like low testosterone, you could not be in the study.
Right.
Okay. And they randomized the guys and they put them into 2 groups. They put they put him either into a placebo gel group or they put him into a testosterone replacement gel group. Again, not a huge fan because they use gel, but that's just how the study was. And
Okay.
they measured cardiovascular events in each group over a 4-year time frame. Now, and at the end of the 4 years, statistically, there was no real difference in cardiovascular events in the guys that got the placebo gel and the guys that got the testosterone gel.
Hmm.
Okay. Pretty much the same amount of events happened. They happened. So it's not to say that like they didn't happen. There was events. There was heart attacks, there were strokes, but the amount in each group was relatively similar.
Right.
So that's to say that, hey, these guys on testosterone aren't having any more heart attacks, strokes, you name it, than the general population.
Right.
So testosterone definitely doesn't increase that risk, which
Right.
is why they removed it from the black box warning in April.
Yeah.
Okay. There are some caveats with that nobody's really talked about, but I'll talk about them. One, the study was done with androgel. And if you read the actual study, this is why it's important that when they replaced guys with androgel, they only got their total values to 350 to 750. They kind of kept them in that range. So we didn't have guys that were pushing like 1,000,
1,000. Yeah.
1,200. It
Hmm.
wasn't happening. They weren't running doses that high. So, and it was also done with a topical, not an injectable protocol. So we don't have guys that may have a tighter window because cream or gel has, and cream, any topical has a much shorter half-life. So if we use, let's say, like an esterized version of like testosterone cypionate or enanthate, right, where it's going to last and stay in your body, where our free T levels aren't going to fluctuate as much through the day,
Right.
they're going to be in a much more dialed in window
Yep.
where we keep them high. Is that to say that those guys won't have the same problem? We don't know.
Yeah.
Okay. So when I say yes, under the circumstances of what Traverse provided us, there was no difference in either group. But if we can't compare that to say guys that are running an injectable protocol with a little bit higher levels, we don't know.
Huh.
My gut and my professional acumen for this tells me no, it's probably exactly the same. And in all honesty, I think the benefits of being on TRT and using it appropriately, even at those higher values, vastly outweigh
Yeah.
cons.
Exactly. Yeah.
And because I mean, we're seeing guys put muscle on and everything we talked about at the beginning of this episode podcast that is going to increase your longevity and reduce your overall mortality risk. That's what it's going to provide.
Right.
So, um, so yes, but in terms of a pure data standpoint, I can't sit here and say, well, it's the same because it's not.
Yeah.
So you have to kind of, again, the context matters.
Right.
And that's what Traverse was. So we can't quote it as the gospel because it's not really the Shangri-La, but it's something.
Yeah.
Um,
I mean, will they ever? I mean, how do you get a study done? Like, how would you? Because I mean, obviously TRT is becoming more and more popular,
yeah.
right? I mean, it's growing exponentially.
Well, I mean, if we could have done it a few years ago, we could have just pitched to USAID, but
Ah, shit.
no, I'm just
Of
kidding.
course, I missed
I
the boat
mean,
on that.
so yeah, I mean, government grants obviously, accounts for some funding, and then obviously pharmaceutical companies will fund their own if
Yeah.
that's so. Traverse was used
How
androgel,
long do you
so
have to do? You have to do it for 4 years? Is that what it is? Is that like the?
no, I think that was just the study design, and
Mm,
I don't know if it's still ongoing, if they're collecting more data or not. I don't know. I didn't look into that, but you can run a study as long as your participants come back and you can check them.
yeah.
So if you're going to continue to run it, then you just run it till the wheels fall off, essentially. But a lot of studies have like a study window of when we're going to do from a start and a finish,
Right.
and
I mean,
and two,
it would
some of it
be
may get into funding. You know what I
right.
mean?
Well, I
Like
would
we only
imagine.
have funding for X amount of years,
Sure.
so or unless we get more, we're not going to continue the
Yeah.
study. So there's a lot of factors I think that go into it, but
Yeah. I mean,
could
with
you?
the amount of guys that are doing this now, and women too,
Yeah.
um, you would think that that might be something that would they would want to do.
So
Just
I
to
think
see.
what you're also going to see, and this is going to be kind of emerging data sets that come, is like we've always considered like systematic reviews, meta-analyses, those types of things, randomized control trials to be like the pinnacle of evidence. But I think what you're going to start to see is big data, right? And
Yeah.
that is like for example, like guys in my clinic, I know I can sort like I know every guy that's on an injectable protocol, and I can go in and pull all of their blood work and stick it in like a big
A
chart, and like I can
database.
put it
It's
in a
a
in a database, and I can
right.
put it in there and say like, here's what we're doing over
Right.
the next 4 years. So as I progress in time, I have my own internal data to
Sure.
say, well,
Yeah.
listen, I haven't had anybody that's had a heart attack that's been on TRT that started here in four
Hmm.
years and we're running free T values 25 plus on troughs all the time, and
Yeah.
we don't have any increased risks of heart attacks or strokes.
Yeah.
you know
That's actually a pretty good idea, actually.
so from my own internal data set, and that data set's growing as I add more patients, so
Right.
it's really good. And I can use this data, to kind of say like, oh, okay, it could, because if it truly were the case, then I would start to see an increase in these events,
Right.
right? But I'm not.
Yeah.
So that's why I say, like, even though Traverse isn't the be all end all, I'm still I'm
Able
still
to.
seeing the
Yeah.
benefits. I'm still extrapolating those values to what
Sure.
I'm practicing.
Yeah.
So
Yeah, I mean, it
um,
would be, you figure because of the amount of clinics, if there was like a database, the problem is that, not even some, it's the majority of the clinics aren't doing it properly. So you're not
right.
going to get, you're getting the apples to oranges again,
Right. So you
you
have
know?
dosing variants, not everybody that comes to my clinic is going to be put on a protocol that I kind of have my own internal process to determine for
Right.
that patient,
Yeah.
right? And it works out very well. We do excellent. It works out well. It makes a lot of sense, especially the guys that come in and do their consults. They're like,
Sure.
"Damn, this makes a lot of sense." I'm like, "I know." Like, just
Yeah.
nobody talks about this.
Funny
I
that
don't
how
want
that
to. I don't
works.
want to spill out all my secrets, but
Right.
like, once you know it, and you're like, "Well, hot damn, that actually makes a lot of sense." And then
Yeah.
kind of how we craft a protocol and kind of come up to that and get the values that we want to achieve, we just kind of can move forward with that. But my clinic's not going to be, the same as like another clinic.
Yeah. Right.
They might be doing just like one shot a week. They're probably not monitoring SHBG as tightly as I do. They might not care about free T. They may only care about totals.
Hmm.
Like, everybody's, gonna put their eggs in some type of
But that's
basket.
that's the problem
You
because
know,
then if they're taking AI, like their
right?
estrogen, like you don't,
Yeah,
all of that plays into it, and then it's hard
right,
to, you can't. It's again, you're not comparing apples to apples, so then you're
right.
going to get, a hodgepodge of different answers.
I really wish I had like a way to take. I mean, it would have to basically be like people going through like each person's blood that I've drawn
Uh-huh.
and like taking individual values of like once they started TRT. I could do like
Right.
pre values on everybody and then like post values and like aggregate them
See
all
how,
together.
yeah.
But I'd have to have some, see, and that's where, the money comes in, because
Right,
like somebody
exactly.
has to take that and put that data into a database to be able to sort
Right.
it.
Right.
So
And continue it like as it's,
correct.
yeah.
Correct. So it would be really cool to see though, and we would have several hundred guys worth of data on,
Right.
all on
Absolutely.
very similar protocols,
Hmm.
to just track that over the next,
Yeah,
1, 2, 3, 4 years.
exactly.
I'd love to see it. I think it would be
Yeah, I mean,
awesome.
it's just any kind of data research, whatever, good or bad, is
Yep.
helpful. I mean, like, I mean, because this is relatively new, as
Yep.
far as the amount of people doing it and all this, but you know, we don't know long term yet. You know what I mean? Like we don't know
Mhm.
what it's gonna now, but I mean, the more research, I mean, who the hell wouldn't want to do more research?
Yeah,
But
I mean, like I said, I think it's going to be helpful to grow the space, and I'm certainly not a person that's sitting here trying to gatekeep anything for that. We obviously do this podcast week after week after week, because we enjoy doing it.
right,
Um, and it's something we like to do to kind of create awareness for the space. And, you and I don't get anything for doing this other than the enjoyment of doing it.
right,
And that's fine. I think that's great.
yeah,
Wouldn't continue to do it if I didn't enjoy it.
exactly.
Um,
No, 100
and
percent.
and I know, like, when we started to do this, a lot of this was because we were doing kind of TikTok lives and just getting so much of the same questions over and over and over again. And this provides us a more repeatable format without having to like repeat.
Yeah,
You can just
exactly.
come listen to an episode, gain the knowledge from it, and then you have your question answered. And you can
Yeah.
always refer back to it,
Yes.
you
So
know.
it's funny you said that because I did a live the other day. First one I've done in I don't even know how long.
Okay.
I was like, I'm just going to go live, whatever. I must have said 37 times I take 150 migs a week, 50 migs on Monday, 50 on, and then in the delts and glutes is where I
Uh-huh.
inject, and then 27 gauge. It's like I was just going through.
Right.
It's just like one, and I was just like,
It's
oh
like
fuck,
50
this is
first
why I
dates
don't
all
do
over
this
again,
shit.
right?
Like,
10
it's
seconds.
like,
You know.
yeah. I mean, I get it, like, because people are just tuning in and they want, they
Sure.
want, and I
Sure.
get it, but it's like, it just gets to be monotonous. You know what I mean? We're just like, it's
It does,
just,
and I think that's the hard part about like the live format. Like it's cool because you're actually
yeah. I mean,
interacting
you're
with
just talking
people
with people,
in a
interaction,
live
right?
arena, but then people come in with like, you answered this question, and then like 15 minutes later, somebody comes in
Right.
with the exact
They
same
jump
question,
out and somebody else. Yeah. I mean, I
and you're like,
get
I
it.
already answered it,
I
and
know, but
it's
they,
yeah,
I get it. And I'm trying, we're all trying to help, but it's just, I was just like, now I remember why I don't do
I
this.
went live
Like,
the other day for like 10 minutes and like nobody joined. So
yeah. Mine
I
was low
just,
too. Mine usually is very high, but it was low.
yeah.
So
So
I
I'm like,
just,
okay. I'll be honest with you. I'm not a huge fan of doing it anyway. So,
yeah.
um, but
I
we
don't even
are,
I think September, I think it's done in September.
there's no more lives or
No
TikTok's
more
done.
TikTok.
Oh,
I
it's
think,
gone.
I think TikTok, I think they're finally going to punt it in September.
Okay.
I don't think, I mean, Trump
Unless
was
they,
all about it. That's why he kept pushing it, but now what does he need it for now? Like,
yeah,
it's like he's got his own social media. So
right.
it's probably better for him to even have it go away,
That shows you
So
how much I'm involved on social media. So,
yeah,
but
I don't know. I mean, who knows? They say that, but it
yeah, it
just
could get
doesn't look,
extended or
yeah,
whatever.
because there's supposed to be a buyer and there's supposed to be, but I don't know.
Yeah.
They don't want to sell their stuff, but eventually it's all going to come crashing down. Then there'll be another one, you
Yeah.
know. We'll all
It'll be
be
the
on.
next
What's
thing.
this? Trump's is what? Truth Social? Is that him?
Truth Social, I think
Truth
is what his
Social?
is.
Yeah.
Yeah.
Uh-huh. I wouldn't be shocked if he's just doing it
Yeah.
so his thing takes off.
Right.
Like,
He should buy it. There you go.
yeah. Right. So, all right. Well, until TikTok's dead, I'll still be on there.
Same.
You
Same.
can message. And if anyone's listening has questions that they want answered, just like we did in the beginning, you can DM Josh or you can DM me, and we will gladly answer your question. And, it may not even be related, but we'll just throw it up there, answer it, and talk about whatever we're going to talk about. So, yeah, I mean, any questions, comments, concerns, shoot them
Yes.
over.
I will not review your blood work though.
No, no, we won't go through that.
Not like through a DM. I mean, if you want to like book an actual appointment and have us go over it then. Um, but I'm only doing that for international clients. So if you're in a different country and you want me to do it, yes. If you are in the United States, I will not do that for people in the United
Oh,
States.
Josh, will you do if some people may not even be on TRT because
Mhm.
I've actually had this like where guys said they're not on TRT, they don't need it, they feel good, whatever it is. Maybe they don't like it, I don't know. But they are interested in peptides. So
Yeah.
they said, "Well, Josh," and I said, "I don't know,
Yep,
you're gonna have to
we
reach
do a
out."
lot of peptide consults actually. The pricing structure is a little different for the peptide consults.
Okay.
They're a little cheaper because we don't have to get blood work for those. And obviously, we should know what issues are going on before you do because I'm not just gonna sit and talk about every single peptide.
Yeah,
Like
well,
you should
yeah.
have an idea of what you want to, kind of what
A
route you want to
Google
go.
search could help you with
Yeah,
that.
but we get a lot of those actually, and I'm getting a lot recently for that, and so BPC 157, TB 500 for like wound healing, not wound healing like an open wound,
Yeah.
but like tendonitis or
Yep.
musculoskeletal injuries.
Hmm.
We've been seeing a lot of really good results with that. People getting kind of back at it a lot quicker. I know you've used it. I've used it
Hmm.
myself. I can contest that it didn't get rid of it 100%, but it did
Right.
improve it,
Sure.
versus where it was. I mean, and I even let mine go for like a month and a half, just thinking that it would just, hopefully go away. And it was not. And it
Yeah.
didn't start to get better till about 2.5, 3 weeks into my BPC TB journey.
Yeah.
And then I'd say whenever I was done, I probably could have did it another month, but I was like, and I got about 60, 70% better. And I
Yeah.
was happy. I was happy with that.
That's pretty much what mine was. I mean, I did it for 4 weeks, and it wasn't until week four that I
Yeah.
noticed something. And then when I stopped, I noted the following week after I noticed that it was improved, but it probably improved maybe 50, maybe 60%,
Yeah.
something like that. And I would have done another month, and it probably would have made a big difference. But
Right.
I was starting the CJC,
Yep.
and it's like I know everyone's going to say, well, you can take, and I do, I know that. but I'm not a pincushion dude.
Yeah. I think
Like
it
I
gets
don't
to a
do.
point where you do get some needle fatigue. Like you're
Yeah,
just tired of jabbing yourself
right.
every
It's like
single
every day
freaking.
doing, this, doing. I'm
Yeah.
like, all
You
right.
just want to
So
take a break. And I get
yes,
it, right?
yep,
Like, and obviously like the whole idea of using the peptides to like fix something or enhance, whatever,
yeah,
so like if that elbow injury isn't, if you don't think doing it another month is really worth it because it got good enough, then don't do it. Like you
right.
don't have to. Like it's purely subjective
That's
at that
exactly
point.
it. Yeah,
So,
yeah. Oh, you
but
know what?
no,
I just thought of something, Josh. Someone messaged me. This might have been in the live, actually, now that I think about it. If there's a state that you don't serve, right? Let's just say Georgia.
yeah.
Okay. You don't serve Georgia. If they fly and come see you in person, right?
Mhm. Yeah.
Are you able to mail them? Like, can they be a patient?
Yes,
And
they
then,
can.
okay. And then how often do they have to come back?
Every 2 years.
And that's what I told the guy. I thought that's what you told me before.
Mhm.
Because he said,
That
oh
is
man, I
the
didn't know
Ryan
that.
Height Act. And if we establish an in-person client provider relationship, I can treat somebody for up to 2 years.
Okay. Because the person that I talked to, there might have been, no, there was somebody on the live for sure that said that. But there was another person that might have been on TikTok that said something about wherever he was, he for work, he's always in Virginia. And
So here's the thing for telehealth, the way telehealth laws work is it's where the patient is at the time of the visit.
right,
So you could be a resident of, let's say, like Louisiana. I don't treat Louisiana, and Louisiana is kind of a challenging state to get in. Alabama is another challenging one. Let's say you're a resident, but let's say you're in Virginia and you're technically a Virginia patient at that time if you're in Virginia when we do our telehealth visit. Now, if you go back to Alabama, then you're an Alabama patient at that time, right? So it goes by where you're at the time of the visit, not necessarily by your address
okay, okay. Because
for telehealth.
yeah,
Now,
so
if you let's say were Alabama and you came and saw me in person and you went back to Alabama, we have now established an in-person
right,
consultation. That is different. But
right,
for strictly telehealth,
yes,
meaning it's telehealth initiated out the gate and then it's telehealth followed up. Now, if you come and see me in person, yes, our follow-ups can be telehealth, but we had that in-person
yes.
established visit.
That's the message that when I was going back and forth with this guy, it was on TikTok. He said he always flies a few times a year to Virginia, and he's like, and I would drive
Yeah.
to his, and I was like, I
So
think that you
so if
can
he
do that.
did, like I said, I could do him as a telly, but I could only do him the one time that he was in if it was just a telly.
Right.
But if he were to drive to see me, then yes, we could just do it
Okay.
whenever at that point. It
Yeah.
wouldn't matter where it would be because we could just treat him. Now,
Yeah.
again, still applicable to some of the state's laws. Like if somebody wants to fly in from California and I see it, I can't routinely just send medications to California because getting compounding pharmacies California license is challenging.
Huh.
So the way things work for that, so I can't just say anybody can kind of come fly to see me. There's still some restrictions for some states that make it
Mm,
challenging to kind of fall under, let's say, like my business model and like
right.
how our clinic works, right? So I still kind of have to, you know, there's still some nuance to it. So it's not universal, I guess I should say.
So you're saying there's a bunch of red tape in California? Huh, that's shocking.
Who would have thought about that?
Wouldn't believe
Yeah.
that.
So I have
Bastards.
contracts with like 6 or 7 different compounding pharmacies, and none of the compounding pharmacies I currently have ship to California.
None of them do?
Maybe one. Let me check. Let me look.
Really? Is it that much? I mean, that's much red tape to get through?
I don't know the issue. Um, so I have one pharmacy that will do it to
Mm,
California. So I guess I
mm.
could. So, but Massachusetts is having a hard time right now. A lot of pharmacies won't ship to Massachusetts. This is
What?
recent. They apparently just passed some law. I don't know because
Oh,
I don't treat Massachusetts, but
huh.
yeah. So they're having a hard time getting meds shipped into Massachusetts from I don't know if they suspended a lot of compounding pharmacies licenses for in those states, because the
Hmm.
way it is compounding pharmacy has to get a license to operate in that state in
Right.
order to send medication. I think this whole system needs simplified. It's a little too egregious, if you ask me,
Of course.
but it is
It's
what it is.
government. There's
Government.
nothing government is streamlined and efficient. It's always
Yep.
just one big clusterfuck. It's what it
Yep.
always has been. From local to state to federal. Just
Yep.
gets the clusterfuck just grows. Just because it starts out and it just gets bigger and bigger.
Yep.
So
But yeah, we can do peptide consults, and obviously any of the states that we service. Obviously, you can come in and see me in person. For those, we actually have a lot of people do that, so you don't have to just use us for hormones. I do want to preface that I will never, ever, ever use research grade anything in my clinic.
right.
Everything is pharmaceutical grade. I'm not throwing shade at people that want to do research grade stuff. You do you. I'm just saying, as a provider that's supposed to offer legitimate products, I offer legitimate products.
Right.
So, um,
Yeah, so that they know the prices are going to be more than what
they're
they're.
going to be more, but they're going to
Yes.
be legit. They're going to
Correct.
be real. And they come with instructions. They come with everything you need to get it done. They come with the syringes and alcohol swabs and mixing kits if necessary, and instructions on how to do it and the appropriate dosage. So you get what you pay for.
Hmm. I think I've heard that before. I don't know. Maybe I haven't.
Quality and cheap are
Right.
not in the same sentence.
No, you
So
get one or the other.
you get one or the other.
So, all right. Well, I guess we can wrap it up. So, heart health and TRT. It's all good.
Yeah, it's not harmful to your heart. If used appropriately and without getting in too technical into the weeds, it's completely a-okay. And actually,
Yep.
if you're hypogonadal, you'll probably end up reducing your risk overall for any long-term heart complications. So,
Yep.
if
Beautiful.
anything, do it for longevity, and that's one thing.
Sure.
And I will preface right as we end here is it's not about the muscle building. It's not about, um, it's about being healthy as long as we can and keeping
Right.
the quality as high as we can. That's
Yep.
that's what it's about. So, while everybody's focusing on erections or whatever, you know, behind the scenes, we're focusing on bone density, insulin sensitization, endothelial capacity, how well your heart, muscle mass, VO2 max. Like these are things that we're kind of like looking at kind of under the radar because they're things we don't notice,
Right.
right?
Right.
Like they're not things that we're like, I feel so much better. It's just they're just happening.
Right. Exactly.
So yes, look at it in that light, and it does change your perspective on it a little bit.
Yeah. Okay. Well, hopefully there'll be a study coming out. And
We can see. I mean, like I said, I can aggregate my data, and we can certainly put some things together here
yeah,
in the next couple of years,
it
and
would be
maybe I
nice.
should and publish it. I think it would be pretty interesting.
Yeah. I'm going to try to get some funding for TRT data, and we're going to do a TRT data study.
Hey,
Like it's not going to
I
be.
can print out all the data, and we can go. The only thing, because we can just leave people out of it, we can just
I'm
put
going to
raw
tell you right
numbers
now,
in.
just like everyone else does, it's going to be terribly skewed to the testosterone cypionate side. Like this stuff's magical. Like, yeah, no shit.
Well, it's like everybody says, once you hit that 6 months mark, and you're feeling good, like why would you ever turn back? And
Right.
I
That's
think people
exactly
are
it.
just so hesitant from all the negative stigmas, but then when you're finally on it, you realize that that stuff's bullshit.
Yeah. That's the thing.
So
Like people always say, like, if do I have to be on it for life? I'm like, you don't have to, but you will
no,
be.
you will be.
It's like you
You
don't
don't have
have
to,
to
but
do
you
it,
will be.
but you will be.
Yep.
Just try it for a little, and then you let me know. If you want to go
Yep.
back to feeling like this, or do you want to feel like that? It's up to you. You
Had a
know.
guy recently that said that exact thing. He ended up getting really sick. I just did his follow up this week, and he's like, I got really sick and I couldn't take anything for like 2 weeks, 3 weeks. And then he's like, and then I went on vacation because I finally got better, but I forgot to take it with me.
Oh
So
boy.
he went like 3 weeks without. And he was like,
So,
yeah, let me tell you, it was noticeable.
yeah. I
Like
mean, well, you can go like a week, right? Without. I mean, that's
you
won't
can
be.
go a week ish and then you're
Yeah.
gonna, but after that, you're gonna
Starts
like,
tanking.
yeah, and
Starts
your
dropping
brain
like a
will not turn
rock.
back on. So like you don't even make your own testosterone for weeks after you stop. That's why we have to PCT people.
Yeah.
So like when you
Right.
go low, like you go low.
Yeah. Oh
So
boy.
Yeah, he was like, "Yep, I noticed. Like, it was definitely some problems."
That's the
And he's
first
like,
thing I packed when we went away. It
yeah,
was like the testosterone went in first. She's like, "Where's your
priorities.
underwear?" I'm like, "I don't need fucking underwear. Put this in here." It's like, make sure this doesn't get damaged.
Yeah,
Oh God. All right, Josh. Well, another good one. Thank you very much.
you're welcome.
So heart health, and we will be back next week.